Good day, and thank you for joining us for another IISE webinar in our Global Performance Excellence series. I'm joined today by Dale Shattenkirk from the Poirier Group. Dale, thank you for taking time from a busy schedule to share with us.
It's my pleasure.
And this is for many of you will remember that this is the third webinar in a mini series focused on transformational change leadership in healthcare with a focus on performance excellence improvement. I want to once again thank you, the participants, for joining us from around the world. We'll share how to get access to the recording and the presentation tomorrow. You'll get a post-webinar email that will give you links that you can access to get to the presentation, PDF of the presentation, and also the recording itself. And as we go forward with our webinar today, if you have any feedback or observations or questions, feel free to share those with us using the chat function, and I'll be monitoring those. And when we get to the tail end of this, we'll have some time probably for some Q&A and dialogue with Dale. This is the general format that we're going to use today. David Poirier was planning to join us and is having some technical problems. I don't know whether he'll be with us or not, but we'll press on. The quote on the right, we used this in our last webinar. I think that I'd like to think that this mini-series, healthcare is obviously very large, complex, dynamic, and none of us are complete experts, if you will, in terms of how to fix healthcare, so to speak. It's too big and too complex. But the one thing I think that we wanted to do with this mini-series was look at healthcare through a slightly different lens. Look at it through a integrated systems engineering perspective, so to speak. Think about it from an end-to-end system. And I think that's one of the things you'll hear in Dale's presentation today, is that we really need to tackle this from a systematic perspective and not try to tackle pieces, fix it piece by piece, so to speak. This is as I said, this is the third webinar in our series. Back on the 26th of April, we had a really great case example from Ohio Health, and Dale will actually have a case example. It'll be part of his presentation today. So we want to make sure that we're grounding our theory and our approaches and our principles with reduction to practice. And then we've got our annual IISE conference coming up, and our performance excellence track will be in Montreal next weekend, as a matter of fact. So I'm looking forward to flying up there on Friday, and hope to see some of you there for our annual conference in Canada. Our first webinar involved Debbie Nightingale, Thomas Davis, Bob Gold, and Todd Schneider. So Thomas is with Duke Healthcare, and Todd is with Ohio Health, as I mentioned. And some of the key points from that initial webinar, and I'm just going to highlight a couple of them, is that, and I think everybody agreed in that first panel, healthcare system improvement requires an extended system approach. You really got to think about this from an end-to-end value stream improvement perspective. And you've got to figure out a way to get all the stakeholders sort of engaged and involved in your efforts to make the system better, which poses challenges. I think that the other thing that came clear in the first webinar was that this really is an integration of strategy, technology, process, and people, and it's super critical in this industry. That's true for most companies and organizations today, but it's even more critical for healthcare. And then I think the thing about healthcare that's also challenging is, if you think about the core technology, which is preventing and treating diseases, and all the research and the teaching that goes along with that, and then you layer on top of that operational excellence, improving not only what we do, that is, we treat diseases and we prevent diseases, but we also want to have organizations that are effective and efficient. So balancing resource allocation to the core, what I would call the core technology of healthcare, with the enabling technology that allows healthcare to deliver the value that it needs to deliver is very challenging for leaders today. So I think those are three of the things that came out in the first session. And one of the things we focused on in both the first and second webinars is solution elements. I'm not going to read through this list because I want to get to Dale quickly, but these are examples of 9 things that came through Dale in the first 2 webinars as components to the solution, so to speak. And specifically in Todd's case example at Ohio Health, he talked to us about how they've gone about, for the last 20 years, how they've gone about strategy and policy deployment, e.g. Hoshin Conry, how they've been doing tiered huddles, how they've been blending integrated Lean Sigma and business process improvement into the work that they've done. He talked about balanced scorecard and visible measurement systems. And then he also talked about flow workshops, how they've been able to get cross-functional flow workshops. So those are 5 examples of things that Ohio Health has been doing. And I know from looking through your slides that those play out similarly in your pitch today. So I'll jump in for David here. David is the CEO and founder of the Poirier Group, and I've known him, worked with him for over 30 years as a transformational leader for many large-scale organizational transformations, very successful in industry, starting his career at Loblaws. He was able to be a part of a team that took stock price from $6 to $60 in 10 years at Loblaws. Major impact in the ability of the organization to position itself in the marketplace and be operationally excellent. He's got broad industry and situation experience. He brings a visionary and generative learning and leadership perspective to things. Strong emphasis on power of vision and an industrial and integrated systems engineering foundation knowledge base. And the only reason I showcase Dave's background a little bit is because Dave has attracted some very unique and impressive resources around him, Dale being one of our latest. And I think Dale is headed in the same similar career path. The question I was going to ask David is what's his vision for TPG in relationship to contributing to healthcare? And I think his answer, Dale, I mean, you've talked with him a lot. I think that he wants to serve the higher good. He wants his organization to serve the higher good. And healthcare is an industry that's in need. And I think that he truly believes that integrated systems engineering holds some keys to success for healthcare and wants to make a positive impact in this industry.
Yeah, no, that's 100%. That's been our conversations over the last almost 6 years as he was convincing me to join the crew. So.
Good. So I think we're all interested, Dale, in hearing what you have to say and share with us about how you see transformational leadership playing out, and as we attempt to continue to improve healthcare in North America.
Well, thank you very much, Scott. So I appreciate this opportunity to speak on healthcare and the experience that I've had over the number of years that I've been in the system. So I started if I go way back into the 1992, I actually started a manufacturing company in Moose Jaw, Saskatchewan, and it was a brownfield site. We were producing medium voltage underground cable to eliminate overhead power lines, and that was my first entrance into the lean world. And over the 16 years that I worked in manufacturing, and in 1999 when we did bring in Lean Six Sigma, we were very successful. I had some of the greatest mentors you could ever ask for. A very blessed career so far, about all the different people that had joined and taught and gave me advice along the way. In 2005, we actually won the the industry top 10 plant award, only one of two facilities in Canada to ever win that, and that got me on the front page of the Moose Jaw Times Herald, which for those of you that are familiar with Moose Jaw, it's a small 33,000 person community in rural Saskatchewan, farming community, and my sons were on the front page for tobogganing down a hill and looking at model trains. I just had to transform an organization to get us there. But it garnered the interest of the local hospital and health region because they wanted to start implementing lean. So Edna Steckin came over, and after a few hours of seeing what was going on, went into the plant manager's office, said if he was any type of good corporate citizen, he'd have me come to the hospital every Friday to help them start implementing lean. So this is back in 2005, and um, over the next 2 years, we not only took that health region, but the whole province forward, and started to use, a lot of the stuff that was happening down in Virginia Mason, and stuff that was already going on in the States, and start to implement it in Canada. And we were the ground zero for lean in healthcare in Canada, along with St. Boniface Hospital and Hotel de Grace in Ontario. And that really launched my tenure in healthcare. And we received a Lieutenant Governor's Award for Health System Transformation provincially, and it paired nicely with my lean background, as well as my professional background as a human resource professional. And my focus wasn't on why individuals do things, but why an organization does things, why the collective does things. I always joke that I'm messed up too much to be an HR professional to tell someone else how they should be leading their life. I'm okay with moving a group forward. I'm the one-on-one. I haven't got my life figured out. So, the things that I want to talk about today, I'm just going to walk through these and be very mindful of time. So we'll have the deck, and anybody can feel free to reach out after and ask, further or more in-depth questions. But just kind of talk about what the timeline is if you want to change a whole health system, and as this series has been about, is what's the leader's responsibility in that? What are some of the tools that we've got, the model that we use to help actually transform a full health organization, and then a case study, and then some open dialogue, as Scott has indicated earlier. So I always love this picture here, and the quote from Paul Sappho that don't mistake a clear view with a short distance. Pretty much anybody that you talk to has a vision for what it would take to actually change healthcare. It's one of the those topics that always comes up in any discussion that you have when you start talking about anybody's personal life, and just because it might seem like you can get to the end of it because you can see what it might look like. The term that Scott used, healthcare is a complex adaptive system, and because of the size of it, as you're trying to change it, that takes time, and as time goes on, the system is changing itself internally. I like to use as a timeline, when I started in healthcare back in 2005, it had just come to the forefront that being able to do a hip replacement, and you could go in, and 5 days later you could come out walking out of the hospital. And today, so that's whatever, 19 years later, my father-in-law went in for his hip replacement, went in on a Thursday morning and walked out Friday afternoon, and that's an important part of this system, is understanding that it's evolving as fast as we can try to adapt to it, and the better we get at delivering care, and the shorter timelines it takes to deliver those levels of care, increases the workload on staff internally, which is one of the things that are holding us back from being able to make significant change. So a typical journey, there's a lot of healthcare organizations. When I say organization, I'm talking, from public health all the way through to long-term care. There's a lot of organizations that are in that 1 to 2 year period repeatedly. It's like they just can't get their traction. They're doing some projects, they're doing little bits of work here and there, and are improving things for individuals and for some patients. But Then there's a smaller group that can make its way up into the second level of this, which is around that 3 to 4 year timeline where they're actually using it more systemically throughout the organization. They're tying things together. They're actually using being able to support their strategic plan and direction to move the organization forward. But there are very few that are able to make it up into that year 5 and beyond, because the biggest component here, and just as some of the previous speakers had indicated, is leadership. And there's a few things, and I'll allude to these further in the conversation here. The changing leadership is a problem. If your board, and if you're using a board, if a board's not staying true to the path and the strategic plans and the overall vision for the organization, the change of a senior leader such as the CEO can dramatically change the direction. And then all of a sudden, you're up into year 5, and then the next thing you know, you're back down into year 1. So this growth curve is important to understand. And as we come back to the complex adaptive system, you have to paint along there the evolution that is happening now within healthcare, and everything from robotic guided MRIs and robotic surgeries that are happening, and how that actually changes the way the organization operates. Never mind how the leadership has to lead. So I present 2 models here. The one on the right is kind of the altruistic one that we often hear in healthcare about, focusing on patients and patient first. And yes, we have to do that. Or residents first. Yes, we have to do that. But we get very caught up in the qualitative aspect of healthcare versus actually looking at the quantitative aspect of it. We often have a mindset that money is no object, and whatever the patient needs, whatever the resident needs, whatever the client needs, that's what we're going to do. But at the end of the day, that's not how it works. There is a limited amount of resources, whether you're in a public system like we are here in Canada, or in private systems like a lot of the States is. And I spent a lot of time in the UK working there as well. But at the end of the day, the true north has to be something tangible. It has to be something that you can actually count and see, and that everybody feels attached to. We here in Canada, we often are labeling this a patient first approach, and what we do when we start to say things like that is we actually disengage the people that we want involved. If you talk to a nurse and you said that, I want you to focus more on the patient, I want the patient to be first, they're looking at you going, why do you think I got into this business? The caring that's going on a given day is very important to understand. And when you try to say, well, we're trying to be patient first, and you're saying that to the people that are focusing on these patients, and they're going to feel that you don't really understand what they're doing. So when you look at the left-hand side of this, having a true north, having breakthrough metrics in place, and having operational, so that you're able to tie directly to all the people in your organization what's meaningful to them, that supports actually getting the strategic plan and the true north metrics in place, or the breakthrough metrics to be achieved. Once you start tying that together on a daily basis, that's when an organization starts to move forward. Everybody pointed in the same direction and looking in the same direction. And as much as care is important, and patient safety is important, and family-centered care, all of that is really important, we need to have something more objective as our true north metrics and our breakthrough metrics, something that people can actually put their hands around. I love this slide, and I use it quite a bit with leadership groups that we sit down and talk to, is that there is a true north, and I'm going to allude to some of those a little further in the deck. What's that one thing? And it has to be one thing that you're focused on. What is it that everybody is trying to achieve? And then often when we pull lean in, all of a sudden everybody thinks everything's a lean project. Everything is about process improvement, when it's not. You're running a very large organization, multi-billion dollar organizations. You need strategic initiatives. What are the things that you're focusing on? Are you putting a new IT system in place? Are you putting an EMR in place? What kind of capital projects and investments are going in place? In the corporate projects, so those strategic initiatives are usually that 1 to 3 years. What are the things that we're doing that we know are going to take a while to put in place, but are important for us to move forward? And then the corporate projects, and these are, you might be doing some organizational redesign. You might be adding different services that you're going to be able to support your patients and residents and clients with, and those are initiatives that are being put in place to help you achieve that true north. And then on the very left-hand side here is the breakthrough objectives. This is where your lean projects and your quality improvement, your quality management system start to come into play, and you're helping achieve these. And when I move to this next slide, and some of you are probably very familiar with this from the Toyota Way, you're trying to get to the right side of this drawing, versus in healthcare, we have a hard time saying no to anything. And we have a hard time saying no to anything because it usually affects somebody's health. And because we're saying yes to so many things, it turns into what you see on the bottom left-hand side there is all these initiatives going on, but we're not focused. We're not staying and trying to finish something. Clara Ballantyne, that used to work with me, always said, focus and finish. Like, get over the finish line and move on to the next thing. I was in southern Manitoba working with a health agency down there, and it had a brand new CEO. He was only in there for a few months. And he asked me, they just brought us on to support, and he asked me to come and sit in on their strategic planning session. And I said, I will, but I don't know anybody in the organization, so I'm not going to say anything. I'll just listen and we can talk after. And it was fine. I listened through the whole session. And at the very end, he asked me, he said, hey, Dale, what do you think? And I said, we'll talk at dinner tonight and that. And he pushed me, he says, what do you think? And I said, how many strategic priorities did you guys just identify and say that you're going to focus on? And he said 51. 51 key strategies that they're going to focus on over the next year. And I asked someone who had been there for a while, I said, how many did you have last year? And they said 47. I said, out of the 51, how many are those 47? And they said all of them. So that's a very common problem. And this isn't an easy task, but to be able to sit down and say, what are the top things that we're going to focus on this year? And let's get them over the finish line. And then next year, let's see what's the top and move. So that you're starting to move more to that strategic thinking, and you're being able to actually engage everybody in the organization because you're focused and you're moving forward on everybody's moving forward on the very same initiatives. And as we start to pull this down, we think of that strategic level to the tactical to the operational, and as Scott and I wrote a couple of things down here, the huddles, wildly important, just as in Ohio Health when they're talking, these are critical to the success of an organization long term. So these are quality huddle boards, and this is Dr. Richard Wedge, actually on the right hand side. He was the CEO of one of the health regions here or one of the provincial health systems here in Canada. And he was probably the most diligent person I've ever worked with as a CEO for going out to the quality board huddles every month. He would make sure that he was there at all the different huddles and talking to everybody. And he'd always joke, and if you knew Richard, you'd understand. He'd always joke. He says, "You know what? This is the first thing I've ever done in my job that actually got me out on my boat more often, is because now when I'm out at the front line, listening to what the staff are talking about at the quality huddles, what their pain points are, I can guide the right resources to support them right there, right then. And because we have the quality board up in front of us, we know that we're all focusing on the right things. And the quality boards look like this, and there's a right side and a left side. We call it a 2/3, 1/3 board. The right side is the 1/3, which says what is important to the whole health system from the organization level, what's important to all of us. And then the left-hand side, the 2/3, is what are we doing about it? What are the activities that we're doing on a daily basis? Everything from a safety cross to there's an A3 report on there for projects that are going on, key metrics that they're looking at. And that's the discussion that happens. So if something's happened over the last few shifts, and we'll keep using Richard for an example here, when Dr. Wedge is there and when the staff's talking about something, so he's using that phrasing of, well, how can I help? What can we do to solve this? And what it does is it prevents that problem from slowly manifesting, becoming larger and larger and larger. And by the time it gets to Dr. Wedge and the rest of the people at the senior leadership table, it has grown into something massive that could be solved right down almost immediately at the front line. So these are a critical part of organizational transformation. And as the previous speakers have talked about, this is something that's not easy to do. To tell the leaders that now, the number one thing that most leaders complain about is they've got too many meetings, too many emails. So now what you're doing is adding a whole bunch more meetings to the pile. And just as Dr. Wedge proved here when going through this actually reduced the amount of meetings he had. He reduced the amount of impact in those meetings. But it's a heavy lift out of the front end. I'm not going to snow anybody on here. This doesn't happen overnight. And it takes very strong principled leadership right from the top to be able to say, we're going to do this. And one of the tools that's really important is there's two tools that are really important. One is creating standard work. Huddles, everybody needs to show up. There was in this very same project where Dr. Wedge was, when we started doing these, one of the senior leaders went out to a location, and the moment that he got there, everybody scattered. They just disappeared. And when he rounded everybody up, he goes, "Why did you guys disappear?" And he goes, and one of the people spoke up and said, "The only time we ever see you is when something bad was going to happen." And for him, that was the, didn't matter how much we coached him and told him, that was the eye-opening moment for him. Because he had felt that he was engaging with people, but he was bringing bad news whenever he came. And 5 to 10 minutes, these are to the point. You're talking about what needs to to happen, what the different leaders can do to support, what people on that, in this case on that unit, were doing to help improve the and achieve the operational plan, which then supports the breakthrough metrics, which then ultimately supports the true north. And this is a visit pyramid. It's very, very simple. So Releasing Time to Care was a program that was put together in the NHS, the National Health System out of the UK. We had brought it back actually to Saskatchewan and started implementing it here. And it was quite amazing. Releasing Time to Care is basically lean in a box that's designed around how nurses are trained. So it was something that was accepted by nurses quite readily because it fit their mindset and how they thought. And how a visit pyramid works is along the bottom you have the dates. So, once a week a leader is going to be coming to the huddles that are happening daily. And as you can see, as the boxes start to stack up there's different levels in the organization come, maybe every second week or every third week or once a month. And you can see this goes all the way up to the CEO and the board. So the people that are running the huddles are going to have these visitors coming all the time. Now, this is out of all the work that I do with organizations, what happens is so if I'm the senior leader that I come, and if I'm one of the directors, it's my responsibility to sign that off that I've been there. And it's an accountability structure for myself to say, yes, I was there. Yes, I did the things that I was supposed to. And yes, I supported. So if the next person that comes up, if I'm a director and someone from the C-suite comes up and sees that I was supposed to be there and I didn't sign off, it's now their responsibility to come and talk to me and go, "What's going on, Dale? Like you're supposed to be there. The team was expecting you there. What was going on? What prevented you from being able to be at that spot?" So now that senior leader can support me in trying to figure out how to adjust my schedule so that I can actually show up and be there, and the importance of it, and to help guide me and mentor. So you build this internal accountability structure to support each other along the way, and you're able to see as you go to these huddles that people are actually doing what they're supposed to be doing and showing up. So to make all of that happen, too often we just put components of an overall system transformation in place. You can just put quality board huddles up, but if you don't attach all the other things to it, that's not going to be able to stand on its own. So we have something that we affectionately call the 20 diamonds. So there's 20 key components that need to be put in place to help create this transformation. So that if we go back to that first slide, getting over your 1 to 2 years and moving into your 3 to 4 years, these are the tools to get you into that 3 to 4 years. And then there are some that take you up into that 5 to 10 years. And I'm only going to speak to a few of these. If anybody's interested in it, we have a very comprehensive workbook on this that we can send out to you to take a look at. But the first one is creating a compelling story. So as a leadership group, you need to come together and say, why are we doing this? You're going to have many generations of people working in your organization, and a number of them are going to have been there, seen that, done that. We've had, these people come in and try to change things before, but you need a compelling story. And that compelling story, sadly, can only be one of two things. It's either a burning platform or a compelling vision. That's what changes an organization. Now in healthcare, the burning platform is pretty much ashes. Like there is nothing but reasons why we need to change the health system when you think about all the bad things that are happening. So what that does leave us with is that compelling vision. Why do we need to change? And you start to put that together, and the senior leadership group needs to develop this together so that whoever asks them why they're doing this, they're going to be able to tell them the very same story, and they're hearing that consistency, and then this starts to tie to the true north. And there's a lot of different components, obviously 20 of them that we've got to, and I'm only picking a few here. Project selection. As I showed in that previous image, there's all these projects going on. And it doesn't mean that they're bad projects, but you need to select the ones that are important. What should we be working on right now? What is meeting our strategic priorities and direction? What is helping us achieve our true north and our breakthrough? So having a good, solid, robust tool that's going to allow you to pick the right ones. And then savings, being able to articulate back through a number of different ways. And I'm not just talking about monetary savings, but there is always a dollar value to these. But things like Manitoba Health, we took 1.9 million patient wait days out per year on the program that we were doing there. Those are things that the people within that health system were proud of. That we took almost 2 million patient wait days out, meaning that people could come back to see. So there's a lot of different savings that are in there. Some that are objective savings and some are more quantifiable and qualitative. So you're actually appealing to everybody in the savings. And then the final of the 20 diamonds, naming is so critical. What you call your program is your branding moving forward. And we strongly encourage you not to call it your lean program. The best one was actually in Mount Pearl. It was a municipality I was helping, and they called their program Make It Better. And because it actually just became a dialogue that they talked about. And when someone would say, this isn't working, someone else could just simply ask, how do we make this better? So this became their dialogue. It's the way that they talked, and that was the name of their program. So when you're creating that compelling story, you're creating a name at the same time too, and you're branding. You're saying, this is why we're moving forward with this. It's critical for being successful in this. And then leadership training. I don't I don't even know how many organizations I've helped move forward and do full transformations with, but one of the first questions I always get asked is that usually the C-suites, they want to be trained up as black belts for some reason. It's like I want to get that credential hanging on the wall behind me, but you aren't the guys that, like, senior leaders aren't the ones doing the projects. They're not the ones that should be the black belts or the green belts. So we've developed what we call an executive green belt course, so that you do get the credential, but it teaches leaders how to run a lean organization. What are the things that you need to do? So it's a 3-day course that the leadership goes through, and then there's these 6 modules that roll out over the next 6 to 9 months. So what they've been taught, now they start to implement. And a lot of these are things that we've been walking through. Visual management. What's the quality boards that go up? How do they actually manage that? What are the key measures that are going to be? What's your breakthrough measures? Your true north measures? Prioritization. How do you actually select great the best projects to work on. Realization, how do you start pulling all of, you've got people that are trained as yellow belts or green belts or whatever level of training you're giving people. How do you start to realize all the stuff you're putting in place so that you're actually moving forward? You can see the dial moving, expanding. We're huge fans of kind of pilot and spread type of work. Health systems, as we, said numerous times, are complex adaptive systems. Where do you start? Go where the willing are. Go where people are going to engage with this. Go where leaders are wanting to see this, and then start to expand out. Build success points within your organization and grow. And then the sustaining, move away from the episodic. We've done some good projects. We're patting ourselves on the back. How do we grow? How do we move from that 1 to 2 years into the 3 to 4 years and the 5+ years? So leadership training is a key component. I know my time is coming tight here, so I'm going to move through this fairly quickly. So this is a provincial health system that we're able to support, and the goal, I've been talking about True North metrics. When we look at an overall health system, so from public health all the way through to long-term care, so primary care, acute care, home care, this is a very good True North metric to create. And in this case, what we wanted to do is we wanted to reduce the overall average length of stay. And most people go, well, that's an acute care measure. That's in a hospital that we measure that. And the answer to that is 100% yes, it's in the hospital. But every piece of the health system helps reduce that number. So expected length of stay, you're admitted, we use something simple, appendicitis. We know how long you should be staying. And overall average length of stay is the amount of time that people are actually staying. And there are more complex and comorbidities that people might come with. My mom has COPD. When she goes in the hospital, it's not for COPD, it's for pneumonia plus other things that are happening. But when you actually do the data analysis on the front end, you'll find that using Pareto analysis, about 80% of your admission reasons are usually in about 16 different bars. So you can actually function and change things within that 80%. So our goal was to get down to 7.5 days over 2 years. So what we did is we created a 2-phase approach. Phase 1 was actually outside the acute care facility, even though overall average length of stay was what we're focusing on. Phase 1 was in the community, and we affectionately and a bit tongue-in-cheek called it, we want to take away the hospital's excuses. Why couldn't a patient be admitted? Why are there patients caught up in the emergency department? Why couldn't someone be discharged? We said we need to take all those reasonings away. We need to understand them. So working with them in the phase 1 is we went out into the community. So looking at public health, the rural facilities that were available, primary care, so our doctors, home care, long-term care, and extended care. So the things that we looked at, long-term care, we wanted to reduce or eliminate hospital admissions from long-term care. It actually takes up 2 beds. If someone's going to a hospital from a long-term care bed, their long-term care bed is held at the same time as now they're using up a hospital bed. So we want to reduce that. It also obviously supports the residents. So doing things like eliminating UTIs through data analysis and understanding how much fluid intake that a resident should have, incontinence products, pressure ulcers, falls, looking at restraints. And so all of that was to reduce residents from going into the hospital. We went to the rural hospitals, and these locations, often the length of stay was through the roof because it was more of a communal effect. And what we couldn't do is repatriate patients from the primary acute care hospital back to a hospital closer to their home because these beds were being taken up by extra long stays. So we put in place what we call expected date of discharge. So within 48 hours of admission, maximum 48, the goal was 24, we knew when that patient was going to leave, and we included them and their families in their care, in the care plan. So they knew when their CT scan was supposed to be, they knew when their ultrasound was supposed to be, they knew when their tests were, so they could all support on getting their loved one out of the hospital in a timely manner. Extended care, primary care, very same thing. We opened up capacity so that someone needed extra support because they had a hip replacement, they could go to this extended care facility versus taking up an acute care bed, and they get the appropriate care. Acute care, as we know, isn't set up to be able to support patients that need extended care. It's just not designed that way. So now you're laying in bed and not getting the proper physio maybe or other care that you need. Primary care, we implemented what's called advanced clinical access, which was created by Dr. Mark Murray out of Veterans Administration in the States. And our goal was to get doctors down to 7 days. We had half of the doctors at same day service. So they were able to if you called up and said, hey, I have a sore throat, you could get in and see these doctors. And the rest we had it within that 7 day. Home care, we made sure that we realigned home care services so that they were working on that expected date of discharge, so that the moment that the patient was discharged, they could go home and they had a home care nurse and their home was set up. And public health and primary care, we looked at the vulnerable population. We got immunization to the full vulnerable population. We actually went a full year without an outbreak in long-term care because of getting to that full population. And then we moved into the acute care location, and we created and by the time we got here, we had actually reduced emergency room visits by 25% without stepping into the hospital, because people were able to see their doctor. They didn't have to go to emergency room. They were attached to a physician. They could get the care that they needed in the population. So the big thing that we created was an overall value stream map for the whole health system, and from there, what we're able to do was create an interactive map. And what it did is all the information dumped from their electronic health records into this map, and it would highlight red where there was any problems, anything that was out of scope. So the senior leadership group every Monday would look at this overall system value stream map and see where the hotspots are, and be able to support to keep patient flow going right from public health all the way through to long-term care. So it helped be able to create the flow that we are always desperately looking for, and the outcomes were really good. So we didn't get to 7.5, we got to 7.6 days on our overall average length of stay by the time we completed the objective. We had trained up a large number of people. I've actually just been visiting with a number of them, and over the number of years they've made their way through the organization. Took roughly $20 million out of the organization for a $1.2 million investment, and that investment included the time for staff internally. So we counted, someone was working on a project, how much resource was that? So the investment that had to go in on the front end, and that. So there was a lot of success, by the time that we were finished this project, and a lot of good outcomes for the patients. I was trying to keep us at least 15 minutes, Scott, so I got us 18 minutes left. So.
No, that's great, Dale. Thanks for that. I think that that was a nice continuation of the conversation that we had with Todd from Ohio Health last month. I guess I'm trying to process everything you said, because everything you said resonated in terms of my experiences as a patient in healthcare over my life, more time with the healthcare system than I would like, and most recently an intensive experience over the past year as a caregiver and advocate for a loved one, and so I've seen it from that perspective too. And then when I was at Ohio State, we did Lean Sigma process improvement projects for Ohio State University Healthcare Med Center. We did about 2 projects a year for 20 years, so had a good number of projects under our belt. I'm struck by again, and I said this at the outset, I really am struck by the systems approach, the extended system approach that you're proposing and that you've done, because I think that is super critical to success in healthcare. And I think that's probably one of the major takeaways for me today is I'm not sure I thought about tackling this thing. I mean, at a conceptual level, I sort of did, but then you sort of showed me how it actually played out, which was cool to see.
Mhm. Yeah, and we did also in a much larger system. We did the same thing, 47,000 staff, and it's all proportional energy to get to that spot. But the speed is important. So the first 3 years are critical,
Yeah,
and you know doesn't matter what size the organization is. We're looking at some stuff with a health organization, 115,000 people, or 47,000 or 4,700. It takes 3 years to get to that spot where you're starting to actually embed this, because it takes that long for people to actually accept the change and put pieces in place and have the repetitive nature of it. But to your point, Scott, that by looking at it holistically, you're doing all of that work over those 3 years so that everybody's moving forward. That strategic priority, the true north metric, the compelling story, getting everybody moving in that same direction for 3 years, the first 3 years, that's the heavy lift. But once you get there, that's when the momentum can take over.
yeah, yeah. And the other thing that to me makes healthcare more challenging in some respects than manufacturing or service provision is that the interdependencies in manufacturing and in grocery, for example, they're linear. It's sequential interdependence. But in healthcare, you have some of that. You've got some sequential interdependence, but you've got a tremendous amount of what I would call mutual interdependence, where it bounces the interdependencies. It's like a swim lane flow map. And you
Yeah.
got like 7 swim lanes, and they're all those swim lanes are interdependent upon one another from a communication and coordination standpoint, which is, to your point, why tiered huddles are so super critical in
Yeah.
healthcare transformation. We had a webinar. CISE did a visit to Emory Healthcare, and Victoria Jordan, who is a past president of IISC, set up the tiered healthcare system. And so we got to see it up close and personal. Every day they do 5 tiers of huddles. They start with the local unit, and by 11 o'clock in the morning, they're at what they call their tier 5 huddle, which is 60 people in a room, basically everybody in the whole hospital care system looking at. And so every day, to your point, every day the senior execs are putting their finger on the pulse of what's making this place work and hum today, or what's not making it hum today,
Yeah. And
And
that's important. And we had, with the value stream map that we had created, we tried to automate some of that, but
yeah,
also very mindful that the importance of standing there looking eyeball to eyeball is critical. If
yeah,
you try to automate too much of it, you can't get there. And your previous comment on, so I've got the manufacturing background as well. And when I first entered healthcare, people would ask me, what the difference is, and my first response was, well, there's a lot less crying in manufacturing than there was in in healthcare, a lot less tears shed. But the biggest distinction for me in understanding why healthcare is exactly the way that you're explaining it is understanding the customer supplier relationship. If I stand in front of my caregiver, um, they're the supplier and I'm the customer. But what happens is the first thing they're typically going to say is, what's wrong, Dale? What are you feeling? What's going on? So now all of a sudden that customer supplier relationship just changed. They're now the customer and I'm now the supplier. And the better that I can supply information to that care provider as a customer, the better my outcomes are going to be. So that relationship throughout the health system is always doing that. Whereas in
yeah,
manufacturing and industry, it's not. It's a one-way street. And in healthcare, we're always back and forth. Always. We have to be very
yeah,
mindful of that.
yeah. I'm with you. So what would be what do you want the attendees to be thinking about today when they reflect on the webinar? What would be the one or two top key points?
Well, there's this old quote that I like. I think it's a Chinese proverb. Is when's the best time to plant a tree? 20 years ago. When's the next best time? Today.
Yeah,
And we come up with many reasons why today's not the best day to start this. And especially for anybody who's on these calls that works in the health system, uh, those those constraints that you're listing today aren't going to change. They're always going to be there. So it's a matter of actually just saying, okay, we're going to do this, getting leadership on board, making sure that they're thoroughly committed and moving forward. That's the first thing. There's like we've presented a model that that's been effective, but there's lots of great health systems out there. Jönköping, Sweden's done an amazing job of redefining healthcare and how it's delivered. And New Zealand, there's all kinds of models to use, but starting that's the first thing. Is this?
yeah, and I agree. I think, but back to your point about leadership, and we just finished a mini series in change leadership, and as we went through those 5 webinars on change management, change leadership, um, the the role of leadership kept coming up. And one of the attendees wrote a note and said, I'm surprised that in 2024 we're still blaming everything on leadership. And I thought about it, and you brought up leadership today too. And I think it's not so much blaming leadership as it is an acknowledgement that leadership, uh, the constancy of purpose and the continuity of leadership is really the issue. It's not that leadership's at blame. It's that we recognize that, like in design of experiment, the leadership is a critical factor. And if it doesn't exist in a certain way, if it doesn't work a certain way, then these types of initiatives are very difficult to pull off. And that's why back when David and I started working together, when he was at Loblaws back in the 90s, they spent 6 months working with the top 20 leaders in the organization, getting a shared vision of what Loblaws could be in 1998. And they were creating that vision, that 1998 vision, in 1990. Yeah. So they were essentially projecting themselves into the future and said, what do we want to be when we grow up, right? And that was powerful, and it took a lot of dialogue. It took a lot of people debating and talking with one another. And then at the end of that exercise, they got in front of a room of 200 people. So those 20 people got in a room of 200, and they all stood up there, and they had a vision narrative that they'd written collectively, and everybody in the room had a copy of it. And they each signed it. They went up and they signed, like signing the Declaration of Independence, and it was sort of goofy in a sense, but it was powerful because the audience said, these guys are committed. They've put a lot of time and energy into that, and they're putting their name down there.
Yeah.
So that was an interesting exercise. And once you do that and you get everybody talking about that shared vision, then you can harness the power of creation, in the sense that people are committed to bringing something into being that doesn't exist yet, but they want it. They've chosen for it. And when you get that kind of power, anything can happen.
Yeah, and that's that whole getting everybody moving in the same direction, right?
Yeah,
and
yeah.
It's a critical piece of the puzzle, and you're 100% right. I'm not blaming leadership for where we are right now. It's healthcare is designed, primarily for emergent services. Like when you need something, the system, you can flow typically through quite well. It's we start moving back more to the elective or episodic care. That's when things start to fall apart.
Yeah.
So there are so many great leaders. Like I've been working in healthcare with thousands of people, and they're there for the right reason. They want to make things better, just having the tools and
Yeah.
and direction to get there. But
Yeah.
I just want to say, like, there's three good questions in the Q&A, so I'll respond back because there's only 5 minutes left, so there's not enough time for me to verbally answer
Yeah.
these ones.
Yeah, real quickly, because I got a couple things I want to do to close out here. Yeah.
Yeah, so well, what I'll do is I'll respond back and like I'll
Okay,
send,
I'm with you. Yeah, that's fine. Yeah,
so
that's good.
I can
Yeah, so
appropriate.
we'll have a record of this and we can get back to them. Yeah, good. Okay, so Dale, thanks very much. This was fantastic. Loved it, and appreciate you taking time to do this.
That's my pleasure.
So real quickly, for those of you still on the call here, there's still a good number of you that are hanging around here, and I appreciate that. You will be able to find this recording and the presentation on the IISC website. It'll be in the Industry and Service Systems 4.0 bucket, so to speak. This is an on-demand part of the IISC website where you can on-demand go and get access to these webinars. It'll look like this. So the bullet at the top, the next bullet at the top will be the webinar from today, and tomorrow you'll get a link to take you there. I will say that at the end of every one of these mini series that we've been having, we write a capstone article and it gets published in the ISE magazine. The article for healthcare transformation will show up in July. I'm currently writing it right now. And we've had articles on AI and leading transformational change and operational analytics. So that's another benefit of being a member of IISE. If you're not and you want to consider it, I'd encourage that. For those of you that are thinking about going to Montreal, still time to register. We've got an AI symposium that's going to happen next Saturday, and then we've got the CISE Performance Excellence Tracks, which will happen on Sunday and Monday. So I'll stop there, and once again, thank Dale for taking time to do this today. And everybody, please stay safe and stay healthy, and we'll see you next time.